Hi, good evening, everyone, and thank you for joining us tonight. My name is Laurie Trangone, and for those of you who are new to us, I'm the Assistant Vice President for Women's and Children at Inspira Health. We have a great presentation in store for you tonight. Before we begin, though, I'd like to cover a few housekeeping items. We're using a new platform tonight with lots of fun bells and whistles for you to play with. Our coordinator, Lauren, calls it the Cadillac of platforms, so it should be fun. So feel free to click around and explore. All the windows on your screen are resizable and movable, so you can move them around to get the most out of your experience. You can enlarge the slides by clicking on the arrows in the top right corner of them. And at the bottom of your screen, there are multiple tools that help you be engaged and participate in this webinar. Using the toolbar, you'll be able to download the slides and other resources that we'll have available for you. You'll be able to look at the bios of our speakers and even register for the next event. As usual, we encourage you to ask questions throughout the presentation using the Q&A button that's on the bottom. Your questions will only be visible to us, and your identity is anonymous, so feel free to be comfortable enough to ask whatever's on your mind. Throughout the presentation, you'll see some poll questions that'll pop up on your screen. We want you to respond to them, and like any other question that you may ask tonight, your responses to that are also anonymous. So we really want you to participate so we can see sort of where you are, and that's really what makes this fun anyway. Before you ask the question, yes, this presentation is being recorded, and you will get the ability to see it on demand using the same link that you used tonight, and we'll be putting it on our Inspira website as well. So let's get started. It's my privilege tonight to introduce you to our panelists, who are two of our trusted physicians through our Cardiac Partners program. We have with us tonight Dr. Kurt Kalbach, who is an interventional cardiologist with Inspira Health. He completed his medical degree, his internal medicine residency, as well as a fellowship in cardiovascular disease at Hahnemann Hospital. He was a clinical assistant professor of medicine at Hahnemann University Hospital for 25 years and is the clinical director of the critical care and step-down units at Inspira Medical Center in Mullica Hill, and he's the clinical director for cardiovascular services at Inspira Health with us. He has served on the board of directors for our Cardiac Partners since its inception. We also have with us tonight Dr. Niku Thomas. She is a board-certified physician in cardiovascular disease with a special interest in echocardiography. She's a member of the American College of Cardiology and the American Society of Echocardiography. She received her medical degree from Harvard Medical School and completed her internship and residency in medicine at New York Presbyterian Hospital, and then continued her education with a physician scientist fellowship in general internal medicine at the Hospital of the University of Pennsylvania, and a fellowship in cardiology at Temple University Hospital. So welcome both of you, and thanks for joining us tonight. So we're going to begin with the question, how can we keep our family's heart healthy? As women, we usually take the lead on the healthcare decisions for our entire families, and sometimes it can be a little bit overwhelming. Our families are made up of all ages, shapes, sizes, and fitness levels. So whether you're caring for your partner, a parent, a grandparent, a teen, a toddler, there are simple steps that you can take to help ensure that every member of your family stays heart healthy. So let's get to it. When it comes to women's heart health, knowledge is power. It's very important that women arm themselves with the knowledge about taking care of their hearts. You need to realize that heart disease is a very big problem for women, and we don't often know it or realize it. By gaining the knowledge that you're going to gain tonight and taking some preventive measures, we can help you and the women in your lives, and okay, the men too, live longer, heart-healthy lives. So let's start with having Dr. Kalbach explain to us what Cardiac Partners is and what Inspira and Cooper developed together with respect to the heart and what it means for all of you. Dr. Kalbach?
Well, thank you, Laurie. Cooper University Healthcare and Inspira Health brought together their cardiac services from both organizations and formed this new collaborative organization that we call Cardiac Partners at Cooper and Inspira. We established the affiliation in January of 2018, so it's been almost 3 years now, and the organization provides patients in the South Jersey region that the two networks serve with access to coordinated, comprehensive cardiac services across the continuum of care. The combination of the two systems, heart services or cardiovascular services, makes Cardiac Partners the largest cardiac program in South Jersey. The network includes more than 65 clinicians. It's an innovative delivery care model that provides what we believe to be better access and more efficient access to high-quality care in more locations in South Jersey than any other organization. And what this means for patients is that we've got more experts in the region. We can coordinate your care from diagnosis to treatment, whether that's a minimally invasive treatment, medical therapy, advanced cardiac procedures and surgery, and even cardiac rehab. And the patients can remain with the provider of their choice, and that provider can help guide them through their plan of care to ensure that they get exactly the appropriate care that they deserve based on their specific needs.
Very good. Thank you. So let's start with asking the audience, true or false? Heart disease is the #1 cause of death for both men and women. Okay. So let's see what you all said. True. So Dr. Thomas, can you tell us some facts about heart disease? And let's see if our audience is correct.
Yes, well, I'm pleased to see that so many people recognize that, in fact, heart disease is the #1 cause of death for both men and women. In fact, in the United States, someone has a heart attack every 34 seconds, and every 60 seconds, someone dies from a heart disease-related event. So in all, every year, heart disease claims 1 million lives. And more people die from heart disease than all forms of cancer combined. So it's a really important disease for us to get a handle on and for everyone to be aware of. When it comes to women, heart disease causes 1 in 3 deaths in women in the United States each year. And 90% of women in the U.S. have 1 or more risk factors of developing heart disease. And there are many of those, and you should make yourself aware of what those risk factors are. More women have died from heart disease than men every year since 1984.
Oh, wow. So it sounds like we need to do some preventive measures. Can you tell us something about that?
Yes, well, the American Heart Association, the AHA, estimates that nearly 80% of all cardiovascular disease may actually be preventable and can be managed by getting regular health checkups with your primary care provider. The biggest key to preventing and battling heart disease is for you to see your primary care provider for your annual checkup. And this allows your doctor to catch problems early before they become urgent.
Oh, very good. Dr. Kolbach, can you review for our audience some of the signs of heart disease?
Sure. Now, and you're exactly correct, Lori. These are some of the signs, not necessarily all of them. But here's 3 important bullet points. Chest pain or discomfort in any form. Men may be more likely to experience crushing or squeezing or burning pain in their chest. It can radiate into the neck, to the jaw, the shoulders, or down 1 or both arms. Women have some potential differences in the way they experience symptoms. A tightness or a pressure in the center of their chest is more characteristic. Shortness of breath is a key symptom as well. Men might feel flu-like symptoms, sweaty, a weak, thready pulse. This can occur in women with or without the chest discomfort. So isolated shortness of breath or exertional shortness of breath should not be overlooked by men or women, perhaps especially women. And lightheadedness. If feeling lightheaded or dizzy for no obvious reason could certainly be a sign of heart disease and should not be overlooked. Some of the other warning signs that we look for are some of the more unusual things. Unexplained fatigue. unexplained discomfort anywhere, particularly if it's related to activity and goes away when you rest. Passing out or fainting may not be a serious condition, but it certainly can be. Swelling of the lower extremities, the legs, the feet, the ankles, a cough that you don't understand, particularly if it gets worse when you lie down at night. What you may consider to be heartburn or indigestion or agita, as my Italian mother-in-law would say, may not be specific to your upper GI tract or a stomach or esophagus. It could be a heart-related symptom. Palpitations can be innocent, but they can certainly be a marker for several forms of heart disease. And we're never happy when someone has extreme fatigue that has no adequate explanation. So all of the symptoms that I described could be due to something other than heart disease. So you shouldn't panic necessarily if you feel them, but you should see your doctor promptly. Pay special attention to anything going on that seems out of the ordinary, especially if you're known to have any of the major risk factors, including a very strong family history of heart disease, diabetes, high blood pressure, high cholesterol, or if you're a smoker.
Oh, very good. So let's ask our audience a little question again. True or false? Discomfort in your back, neck, jaw, teeth, or between your shoulder blades can be symptoms of a heart attack. I'll give you a couple minutes to do that. Okay, I'll give you 3 more seconds. Assume you're all thinking. Okay, so 100% of our audience said true. So, Dr. Thomas, can you tell us if that is in fact true?
Absolutely. So to review, there are many symptoms that can be signs of a heart attack, but let's talk about some of the classic ones. And if you experience any of these, you should call 911 immediately to get help. So what are the warning signs of a heart attack? Chest discomfort, pain in your chest, or a tightness. It doesn't have to be something you consider pain. You can call it tightness or pressure. If it's in the center of your chest or even to the left of center, and it goes away after a few minutes or after you rest, and then comes back when you exert yourself again, that's one of the warning signs, and you should be aware of that, and that should alert you to the fact that this might be a heart attack. Nausea, associated with the chest pain or not associated with the chest pain, could also be a sign of a heart attack, but particularly if it accompanies this chest discomfort that you have. Sometimes the discomfort will be associated with discomfort in your arms, right or left, but more commonly on the left. And keep in mind that the discomfort may also be in your back, in your neck, your jaw, your teeth, or in particular between your shoulder blades. Anything like that that has that kind of quality that won't go away, in particular if it started when you were trying to exert yourself, should raise alarm bells for you that this might in fact be a sign of a heart attack. Heartburn, indigestion, stomach ache, and sometimes, less commonly, but sometimes can also be a warning sign. And then extreme fatigue, particularly when you're exerting yourself in some way, can also be a sign of a heart attack.
So it looks like our audience was correct because you've given those symptoms. And how about the difference between symptoms between men and women? Dr.
That
Thomas.
can be tricky because I like to tell my patients that women don't always follow the textbook when it comes to symptoms that are associated with a heart attack. So both men and women can experience the classic heart attack symptoms: gripping chest pain, suddenly breaking out in a cold sweat with the chest pain. But women will often have less recognizable symptoms, like the pain that's in the stomach, It feels like heartburn. It can go into the jaw, the neck, or the back. Sometimes women will feel nausea that they can't explain, or sometimes women will just feel short of breath when they're exerting themselves, or just all of a sudden, with or without chest pain. So sometimes what this means is that we might not recognize that these are signs of a heart attack, because these are symptoms can be unique to women and don't necessarily make people think about their heart. So it's important to be aware that these can be signs of a heart attack. And remember that time is critical. So when it comes to a heart attack, if you are having one and you're experiencing unusual or any of these symptoms suddenly, the sooner you get to the hospital and seek medical care, the better off you'll be. We have a saying, time is muscle, which basically means that the sooner you get to the hospital and give us a chance to restore blood flow to the part of your heart that is suffering, the better the chances are that you'll be able, that section of your heart will be able to survive, and your heart will stay strong after a heart attack.
Oh, very good. So those are heart attack symptoms. Dr. Callback, can you give us some of the symptoms of heart failure?
I'd be happy to. Shortness of breath, coughing for no good reason, even wheezing. Some people might think they're actually having an asthma attack, but they're having some problems with congestive heart failure. The buildup of fluid anywhere in your body, classically in the legs, down into the feet and ankles, but can also occur in your belly or on your back. Swelling of the hands and arms, perhaps less likely, but any dependent swelling in the lower portions of your body should be brought to your primary care providers or your cardiologist's attention. A sense of overwhelming fatigue or feeling lightheaded, nausea, lack of appetite, impaired thinking, or an unexplained elevation in your heart rate could all be symptoms of heart failure. As I said before, when we were talking about other forms of heart disease symptoms, it doesn't necessarily mean you have a problem with your heart, but you shouldn't avoid getting it looked at and talking about.
So what should people do if they have heart failure?
As Dr. Thomas said, if you think you're starting to have symptoms that might be heart-related, nothing necessarily truly unstable, but you're noticing that you don't feel well, you've had a couple of days or some period of time where you're having some recurring symptoms that you don't understand, you shouldn't wait too terribly long. Please contact your primary care physician and make an appointment to be seen. If you think something acute is going on, if you think you're having a heart attack, if you think you're having a stroke, call 911, right? The shortness of breath, lightheadedness, chest pain, an acute change in your ability to think or mentate. There's no time to be wasted here. As Dr. Thomas said, time is muscle. The quicker you seek attention, the quicker we can help you.
Okay, thank you. Dr. Thomas, is there something that can help people identify if they're at risk? There must be tests and stuff that we can do so that people can understand, if they're at risk.
There are many tests at our disposal that can be ordered if the physician feels that it's indicated. So once you decide that you want to be evaluated for possible heart disease, you'll see your provider, and your provider will gather a health history, perform a physical examination, and based on those things will determine whether or not and which tests get ordered next. And so there are many at our disposal, but the point is that this diagnostic testing will allow for a timely and accurate diagnosis in order to create a personalized plan of care. So what are some of the common tests that you might hear that people might toss around or might actually be ordered for you? There is cardiac MRI or MRA, a CT scan of the heart, or cardiac angiography. These are fairly different tests, but but in general, they let us evaluate the structure of your heart, the function of your heart, and in the case of angiography, take a close look at the blood vessels that affect the heart and that provide blood and oxygen to the heart muscle itself or to other areas of the body. You've probably heard of an EKG. We used to call it EKG. Now we refer to it as an ECG. It's the same thing. It's the electronic tracing that gives us a printout of the electrical signals in your heart, and it tells us a lot about how well your heart is communicating within itself and what kinds of things might have affected its ability to do that. We have an ultrasound of the heart, which when the ultrasound is examining the heart, we call it an echocardiogram. So echocardiography is commonly used, and it's non-invasive. It's an ultrasound like any other ultrasound, at least the typical one, where we take a probe with some gel, take some ultrasound pictures of the heart. It lets us look at the overall structure, function of the heart muscle, and also the valves within the heart, and get some pressure estimates as well. There's a lot of things that we can do with echocardiography. One is we can combine it with stress testing. And in that case, you'll probably be put on a treadmill or have a medication injected in some cases. A treadmill or a bicycle will exercise you, and then before and after we'll perform the echocardiography and see if there's a change in the way your heart functions. And that lets us, again, see if it looks like there's part of your heart that's not getting good enough blood flow because there might be a blockage in its vessel that's preventing that. There's a specialized type of echocardiogram, still an ultrasound, but this time you swallow the ultrasound probe, which sounds worse than it is. The probe is actually very small and you're sedated for it, but it's called a transesophageal echocardiogram. We call it TEE for short. And the reason we might do that is because when there's an ultrasound probe in your esophagus, it's actually placed right behind the heart and lets us get a very good look at structures that sit deep within the chest. Obviously, that's a very specialized study that your cardiologist most likely will determine whether or not you need. There are nuclear tests that we do. MUGA test. Sometimes we'll use nuclear imaging as part of a stress test, where a nuclear tracer will track blood flow either within your heart muscle or inside the chambers of your heart and let us see how well blood gets to the different sections of your heart and how forcefully your heart is able to eject the blood. All of these give us important information about how your heart is functioning, if there are blockages there, if you have heart failure or any weakness to your heart that we should know about. So sometimes the nuclear testing is done after a stress test when you're placed on a treadmill or given a medication injection. And again, we look before and after at the blood flow through your heart to see if there's a change that might indicate that you have a blockage there.
Oh, very good. We have a question from the audience. Dr. Thomas, if you could answer this. What is the difference between a heart attack and heart failure?
That's a good question because sometimes we're pretty cavalier about throwing around these terms. But when we talk about a heart attack, we're talking very specifically about a situation where part of your heart muscle has been deprived of the oxygen that it needs. And that muscle actually starts to die. It's as if you've cut off the blood supply to that section of the heart. And if you don't restore blood flow to that section, that part of your heart muscle will die. That's a heart attack. There are different things that might lead to that, but that's what that term means. Heart failure is a condition where, for a number of reasons, possible reasons, your heart is not pumping blood forward the way that it should, either not as efficiently or not as effectively as it did when you were healthy. Sometimes because the heart muscle is weak, sometimes because it's too stiff. But the bottom line is you might end up with blood pressure that's too low, not enough oxygen delivered to your body. Sometimes your blood backs up into your lungs or to your legs, so you get short of breath or swelling in your legs. So heart failure is a failure of your heart to be able to pump blood adequately to your tissue. And a heart attack is a specific event where part of the heart muscle dies because it's not getting enough oxygen to it. a heart attack can lead to heart failure, but they're not always the same thing.
Oh, very good. Thank you. Dr. Callback, as an interventional cardiologist, what can you offer people that's non-surgical to treat some of these conditions?
Oh, Lori, interventional cardiology is really a tremendous area of growth within the specialty of cardiology and cardiovascular disease. We've gone from doing heart catheterizations and doing a bunch of monitoring to fixing arteries with balloons and then stents and using other technologies such as lasers and drill devices. We have catheters available to us to support hearts that are in heart failure. And what used to be left up to our colleagues in heart surgery to do, we can now do several things to take care of valvular heart disease or risk for stroke that 10 or 15 years ago we couldn't do. There is a device called a Watchman, which can seal off the area of the heart where clot typically forms. One of the major concerns when you're in atrial fibrillation is that clot could form and then leave the heart and go to another part of the body, classically causing a stroke. We use blood thinners for those patients most of the time, but some people have a tough time tolerating those medications. They bleed, they have low platelet counts, they have low blood counts for other reasons. They're at high risk for falling and injuring themselves, and we don't want someone to have a catastrophic event if they fall and hit their head, for example. So by going through the groin and inserting a Watchman device to close off this one area of the heart, the left atrial appendage, we can virtually eliminate the need to be on blood thinners long term, yet still protect the patient with atrial fibrillation from having a stroke. It's really a genius design by the tech companies that we work with. Probably more commonly used is TAVR, or transcatheter aortic valve replacement. We have learned how to replace the aortic valve by going through an artery in your groin or an artery in your arm, rather than having one of our surgeons open your chest and stop your heart to do so. This has allowed us to treat a lot of folks that would have been considered too high risk for the traditional surgical option. And the convalescence from procedures like this are much shorter, so there's less downtime, earlier return to function, really a win-win situation for everyone involved. Surgeons still do valve repair and replacement for us when need be. We have very talented surgeons at Cooper as part of Cardiac Partners. But for some folks who have a leaky mitral valve, the valve doesn't close properly. So when the heart contracts and the mitral valve is supposed to close and prevent any blood from leaking backwards toward the lungs, we can now use a clip device to tether the abnormality of the valve that allows it to leak and minimize or hopefully eradicate the leaky problem with the valve and avoid the need for someone to have open heart surgery.
You mentioned surgical cardiac procedures. Dr. Thomas, can you give us an idea of what that might mean in terms of, some of the types of surgeries out there?
Sure. It is exciting that so many non-surgical options are available now. Surgery used to be the mainstay of what we were able to offer patients who have heart disease. And there are some non-surgical options, but surgery is still used widely and most appropriate in a lot of situations, and it's a good thing. The techniques have really improved, and our surgeons are top-notch at Cooper. There's coronary bypass surgery, which I'm guessing a lot of you have heard of already. This is when The people have plaque and blockages built up in the vessels of the arteries of the heart. And so they either can't be opened well enough with a stent, or they're in locations where it would be dangerous or inadvisable to try to place a stent, or they have so many blockages that surgery is still the best option, or depending on what other conditions they have. And what the surgeons will do is actually attach a vessel that's harvested from some other part of the body directly from the aorta and around that blockage, and reattach it to a part of that artery that's a little bit further downstream from where the blockage is. So it really creates a little bypass around the blockage to get blood flow to the part of the heart that's depending on that vessel for its oxygen. And you can do that in a number of vessels. So this is a surgery specifically for coronary artery disease. They create bypass grafts to bypass the blockages. There's also surgery that can be performed on the aorta. Now, we haven't really talked about the aorta, but it's a really important vessel. It's your main artery that comes off of your heart. The heart pumps blood into the aorta, and then the aorta carries it throughout the body, sending branches all over your body. It goes all the way down your chest, down through your abdomen. But the aorta can become diseased as well. The walls can become weakened, they can fill with plaque, and if they start to expand, that's called an aneurysm. And depending on where in the aorta the aneurysm occurs, it might be a dangerous enough situation that you need surgery to protect you from the aorta actually rupturing. I think John Ritter is one of the more famous casualties from a ruptured aorta in the abdomen. So if the surgeons and your doctors determine that you have an aneurysm and that it's either enlarging quickly, becoming too large, or in a dangerous position, there are surgical options to repair that area, protect that area of the aorta, usually by putting a graft in place.
And we hear often about arrhythmias, and people say they have arrhythmias. Dr. Thomas, can you tell us what they are and what people can do about them?
Sure. Arrhythmia is a very broad term that just means that the normal rhythm of the heart is somehow disrupted. And instead of being very organized, it's become either chaotic, or the heart is using unconventional or extra pathways to send signals throughout the heart, or sometimes not using the pathways that are there. So, as I say, it's a broad term, and there are many different options for treating arrhythmias depending on what the problem is. If you have an abnormal rhythm where your heart is beating too fast because a lot of chaotic electrical signals are being sent, or you have an extra set of electrical cells that creates a little endless loop, there's a procedure that can be performed, a very delicate procedure by our electrophysiologists, they're heart rhythm specialists, where they freeze burn some of these extra signals so that endless loop can't continue to conduct. That's called an ablation. So an ablation is when you cut off the conduction through a very specific pathway. Depending on whether or not the ablation makes it necessary, or your heart is just not using its electrical pathways adequately, you might need a pacemaker. A pacemaker is a small device that gets buried under your skin, usually just by your shoulder, and it's attached to some electrical wires that sit in your heart and will deliver an electrical signal to whichever chamber it's programmed to pace, to make sure that your heart rate doesn't fall below a certain level. And it can get very complicated in how it keeps the heart coordinated, but that's the basic idea. His bundle pacing is a more specific type of pacing. And also, if your heart muscle is weakened, or if you have very dangerous rhythms that can put you into cardiac arrest, you may need a special type of wired device called a defibrillator, an ICD. And that is also buried under the skin near the shoulder, attached to a wire that ends up in the heart, But in this case, it monitors the heart for that dangerous rhythm, and if it detects it, will deliver a shock to convert your heart back out of that rhythm into a safer rhythm for you.
We do have a question, if you don't mind answering, Dr. Thomas. One of our attendees' husband had an ablation years ago and was told that it could possibly come back. And the question is, how long does it usually last?
Well, if the ablation has identified all of the cells in an extra circuit, it shouldn't come back. But the reason that people sometimes will get a recurrence is that these electrical pathways could be complicated, and there may be a second bypass tract, or it may have been wider or a little more complex than was originally recognized, and so not all of it was eliminated during that ablation. So it's not so much a time period it doesn't regrow. It's more a question of whether or not all of it was eliminated in the first place.
Oh, okay. Thank you.
Complicated procedure, and it's not that anyone did anything that was wrong. It's just sometimes that happens.
Okay. Thank you. So before we get to the next topic, let's ask our audience if they understand or know what cardiac rehab is. So the question is, cardiac rehab programs usually consist of exercise, healthy diet, stress reduction, medical therapy, and smoking cessation. That's the first answer. Or weaning off substances that affect your heart, or recovering from a breakup and mending your broken heart. I'm sure we can all relate to at least that last one. So we'll wait for some of our audience to respond a bit, and then we'll have Dr. Kolbach tell us about cardiac rehab and whether or not you are correct. I'll wait another 3 or 4 seconds. Okay, so our audience thinks that it is the first answer: exercise, healthy diet, stress reduction, medical therapy, and smoking cessation. So we'll let Dr. Kolbach reaffirm for you that that is correct. Dr. Kolbach?
This is an awfully bright group. I don't think they've gotten any wrong. Listen, I've been around for a long time. Cardiac rehab has been around for as long or longer than I was. 30 years ago, and I am dating myself. 30 years ago, we were largely enrolling folks who had heart attacks and had bypass surgery or valve replacement surgery, and putting them through a 6 to 12 week program where experts in heart physiology, nursing, dietitians, exercise physiologists would put you through a progressive monitored exercise program, in addition to helping you with whatever risk factors you had for heart disease, make sure that you're leading a healthy lifestyle, help you understand what is a amount of exercise for you so that you're not doing too little or doing too much. Over the years, we have changed things a little bit. We'll take folks who have chronic heart disease symptoms, for example, someone who has chronic angina, someone who has a chronically weak heart and needs to be in a regular exercise program so they can be in peak physical condition and peak efficiency, so their body can manage with a weakened heart. We're hoping to develop programs where we can put people into a cardiac rehab program before they undergo surgical procedures to help them prepare for the procedure and shorten their recovery time. The benefits have been obvious for a long, long time. The risk of future cardiac events goes down. Your cardiac and respiratory function improves. Your endurance and strength improves. You're able to perform your daily activities, leisure and recreational activities more easily. There's less fatigue, better sleep. less anxiety, depression, and really an overall sense of an improved well-being. Actually, after saying all that, I can't imagine we don't all try to get into a cardiac rehab program.
Right.
I have to look into whether or not that's possible.
So, Dr. Thomas, can you give us some tips on how we can keep ourselves as well as our family's heart healthy?
Absolutely. This is one of the more exciting topics because this is in your hands. We have a lot of high-tech things that we can offer, medications, but prevention is key, and that's something that you have control over. So one thing that you can do is eat a healthy diet. Lead by example. Show your family that avoiding sugary foods and sugary drinks doesn't have to mean that you deprive yourself. Eat plenty of vegetables and fruits, whole grains, lean meats. If you're going to have dairy, make it low-fat dairy. Certainly avoid fried foods and fatty baked goods. And then exercise is extremely important. The heart loves exercise. It keeps it healthy. So if you get 2.5 hours of physical activity per week, that's great. And although it may sound like a lot, really 30 minutes, 5 days a week will help you achieve that goal. Limit your screen time because your metabolism slows down when you are engaging in screen time and you're not active. And very importantly, quit smoking cigarettes. It's not easy. Nobody expects it to be easy. But smoking does increase your risk of heart disease and heart failure and heart attacks and a lot of other things. But fortunately, quitting smoking really reduces your risk of recurrent heart attacks and cardiovascular death. So it really pays off if you're able to quit smoking altogether. And everyone should be trying to avoid secondhand smoke, no matter what.
And how about stress and sleep? How do they play a role in helping us manage our heart and keeping that healthy?
Yeah, the effect of stress is complicated, and we're just beginning to understand it. But we do feel that it's a very important trigger for heart attacks. Emotional stress, an emotionally upsetting event can be something that ends up causing or triggering a heart attack, especially if it involves anger. And then after a heart attack, people who have higher stress levels have higher levels of stress hormones in their body, and they tend to have more trouble recovering. So and another issue is that some of the ways that we cope with stress tend to not be very good for us, like overeating, emotional eating, drinking alcohol, smoking, for example. So finding healthier ways to cope with stress is important. When it comes to sleep, a lack of sleep is linked to an increased risk of heart disease, increased blood pressure, and an increased risk of strokes. So we recommend that you really strive to maintain good sleep hygiene, as we call it, which is basically behaviors that facilitate falling asleep and staying asleep well. Stick to a consistent sleep schedule, whether it's a weekday or a weekend, no more than 1 hour difference. Use the hour before bed for quiet time, avoiding artificial light, avoiding light from screens, television devices. Avoid heavy meals within a couple of hours of bedtime will help you sleep better. And keep your bedroom quiet and cool and dark. And we find that these things help facilitate good sleep.
That's great. Thank you. Now, we'd be remiss if we didn't talk about COVID and the effect that it has on your heart and your actions. You know, we're still learning as a healthcare field about the long-term effects of COVID on our bodies, and studies are continuing to be done so that we can better understand how COVID's impacting all of our lives. Some patients who have recovered from COVID, we know still show signs that their heart has been damaged, even weeks or months after feeling better. So let's have Dr. Paulback talk to us a little bit about how COVID does affect the heart.
Thanks, Lori. Yeah, you're absolutely right. We couldn't have this conversation without mentioning the consequences of the coronavirus on the body. It seems as though most of what the virus does, or what's obvious most of the time, is related to how it causes inflammation in the lungs and pneumonia in the lungs. But that same inflammatory process can occur in the heart and cause inflammation of the heart. It also lead to, with pre-existing heart conditions, adding more stress on an already impaired heart. It can cause heart rhythm problems to occur, though, frankly, I think we've seen fewer heart rhythm problems, complication of coronavirus than we were expecting. It can also cause blood clots to form, and those clots can lead to problems with the circulation of the heart, just like a clot is part of the process that causes a heart attack, as Dr. We're hoping that the effects of the heart are temporary, but it's going to take really a long time before we know for sure. Please allow us some more time to do some more research and do some longitudinal looks that have been effective. I'm sure the community will be kept up to date as we learn new things and hopefully important things to keep us healthy over the long term.
Very good. So I'd like to take this opportunity now to, we have a number of really good questions that our audience has asked us. And let me start with, how can I prevent a heart attack? I don't know, Dr. Thomas or Dr. Kolbeck, it doesn't matter.
I think that's a great question. I think that, that's sort of the $1 million question, and the advice is changing all the time and evolving. But one thing that stays consistent is taking really good care of your body in ways that you probably already know about. Maintaining a healthy diet and getting plenty of exercise and avoiding things that can poison your heart in some way or sabotage your heart in some way. When you maintain a healthy diet and you exercise, you might avoid diabetes that you might otherwise have gotten. And diabetes can really sabotage your heart. If you have diabetes, keep it under really good control. Any of the conditions that you may develop, either because of genetics or anything else, the sooner you get diagnosed and get those conditions under control, whether it's diabetes or high blood pressure or high cholesterol, the more likely it is that you're going to delay the progression of coronary disease. So you can prevent a heart attack just by taking care of yourself and any medical conditions that develop. You won't be able to make your own diagnoses, of course, which goes back to the very first recommendation, which is see your doctor on a regular basis. Go for annual visits so they can do the typical screening. They'll check your blood pressure for you. If it's time for you to have your cholesterol checked, they will do that and jump on it if it turns out that you have a condition that's putting you at a higher risk of heart disease. And then go to your doctor if you're having symptoms that you can't explain that might be some of the warning signs of heart disease. If you're getting chest pain, get it checked out. It might not be your heart, but if it is, catching it early makes all the difference. You can catch it before it's an actual heart attack.
Very good. Thank you. We have another question. Can you get a heart spasm in your muscle? This person's friend thought she had a heart attack, and in fact, she had a heart spasm. And the question is, what causes this? Dr. Kolbeck, you want to see if you can address that?
I'll try. I don't typically use the term spasm when I'm referring to the heart. There was a period of time in interventional cardiology where we thought that the arteries that supply the heart with blood, because they have muscles inside their walls, that they could, spasm like, a Charlie horse, and that spasm would prevent blood flow to the heart, and that could cause someone to have a heart attack. And then when the spasm resolves, either spontaneously or after giving nitroglycerin, things get better. It's difficult to prove that that's the case. So there aren't, perhaps Dr. Thomas can add some words of wisdom here as well. But I think spasm is a term that we really don't use very much anymore. And we should probably look, or someone should look at what did happen and perhaps offer a more accurate explanation.
Okay. Dr. Thomas, one of the questions is, can a heart palpitation with an increased heart rate above 140 be considered an arrhythmia?
It depends on what's causing it. It's certainly tachycardia, which is the term we use to mean a fast heart rate. But whether it's an arrhythmia implies that it's an abnormal rhythm. And the heart is capable of beating very fast. It can be driven to beat very fast by your own adrenaline, by other hormones, by a stimulant that you take into your body. But if it's using its normal circuitry, then it's not an abnormal rhythm. It's just a fast rate. And if it's using an abnormal circuitry, then it is an arrhythmia. And often, if your heart is beating at over 140 beats per minute and you're not doing anything, you're not exerting yourself, you haven't taken in any stimulants, most likely you have an arrhythmia, and your cardiologist will certainly look very carefully at it and try to capture an episode and determine if it's a normal circuitry or abnormal circuitry. But that's the important distinction to make. So not necessarily, but possibly. Okay.
And we talked about cardiac rehab, and one of our questions is, how do you get into a cardiac rehab program? This person would like to know a good heart rate to maintain during cycling. Dr. Callback, can you address that?
Oh, so a two-part question. How do you get into cardiac rehab?
Yes.
That's a question to ask your cardiologist. Presuming you're requesting cardiac rehab because you have a heart condition for which cardiac rehab is appropriate, your cardiologist would make the introduction. And if everything works out, you get into a program specifically designed for you, to make sure that you get as much out of the program as possible. And what was the second part of the question, Laura?
The second part was, what is a good heart rate for cycling?
Well, an appropriate heart rate with exercise is based on your age and your gender. You can simply deduct your age from 240 if you're a female, or 220 if you're male. Take 70% number. And if when you're doing aerobic activities, you can maintain your heart rate at least 70% of that predicted maximum, perhaps.
Oh boy.
That's a good heart rate for good cardiovascular training. You can do that perhaps because of medication effects, etc. But that would be the idea.
Okay. Very good. Dr. Thomas, does one of the questions is, do you need to take a baby aspirin as a preventative?
Yeah, and that's become more controversial recently. The guidelines have changed. It used to be that we recommended aspirin for a lot of people if you had any kind of risk for heart disease. And even if you didn't, even if you were a healthy person, sometimes, we would think that there was no harm in taking a baby aspirin, and it's been shown to prevent heart attacks. But as we have gained more experience and really looked at the data, those guidelines have changed. So it's a very small number, a much smaller number of people who are advised to be on a baby aspirin to prevent a heart attack. If you've had a heart attack already, you should definitely be on a baby aspirin if there's no reason that it's not safe for you. But if you haven't had a heart attack or a stroke or something like that, then it's much more complicated, and you should ask your primary care provider because they have to calculate your risk of developing heart disease or some kind of atherosclerosis, and that will inform whether or not you're advised to take an aspirin, that along with your age. So it gets very complicated. It's more of a nuanced decision now than it used to be. And the main reason it's changed is because we weren't preventing so many heart attacks that it was worth the increased risk of causing bleeding complications or ulcers from the aspirin. And we always have to do a risk-benefit analysis when we recommend a medication. And in the case of aspirin, in some cases, your risk of getting a complication from your aspirin was higher than the benefit you were getting from taking it. So it's more complicated than it used to be. Ask your doctor about use specifically.
Okay. I think we'll take two more questions, and then any unanswered questions we will still answer, but just not in this forum. So we will answer you. So one of the questions is, what are the ways to improve your injection fraction if it's between 20 and 25? Dr. Kolbeck, can you address that?
Yeah, I'd be happy to. As Dr. Thomas said, the heart loves exercise, but the heart is a different kind of muscle than your biceps or your quadriceps. Exercising your heart isn't going to make it bigger or stronger or allow you to do more. The point of doing cardio aerobic exercises is to improve your cardiovascular fitness, so your body's efficiency is better able to deal with a heart that's not functioning normally. Now, there are particular conditions. After a heart attack, for example, the heart muscle performance may look poor, but the heart muscle will recover over time. It just is stunned from the insult of losing its blood supply for a period of time. And if you give it a couple of weeks or several weeks, it will get better. There are folks that have viruses affect their heart that causes their heart to weaken, and over time it can recover its function. For those patients, both of those patients that I just mentioned, we would typically try to support their heart with certain medications to take some of the workload off the heart or take some of the oxygen demand off the heart, so the heart isn't constantly stressed out. And that should be done by keeping your appointments with your primary care provider and your cardiologist. The defibrillators that Dr. Thomas talked about earlier, there are special defibrillators that help us to what we call synchronize the heart, which can help improve the heart's efficiency. And we can see that in an improvement in the ejection fraction, as the viewer had asked. Lots and lots of stuff. We really should talk about it on an individual basis.
Okay, very good. Thank you. We'll take one more question. I get sinus tachycardia sometimes diagnosed via a heart monitor. What can cause this if you don't take any stimulants? Dr. Thomas?
Sinus tachycardia is just your heart beating quickly, and your heart is designed, when your heart is functioning appropriately, it responds to certain things that drive it to beat faster. If your body needs more oxygen, one of the things your heart will do is beat faster, or it will squeeze harder. If you're dehydrated, your heart will beat faster to try to compensate for the fact that there's less blood in your bloodstream. So if sinus tachycardia is detected on a monitor, then the next step is to figure out what's driving your heart. The problem is probably not the heart itself. The problem is something that's driving your heart to beat faster. And yes, I mentioned stimulants because that's a common condition that causes sinus tachycardia, and most commonly in our country, caffeine from coffee or tea or Coca-Cola or something like that is our main source of caffeine. Nicotine from cigarette smoking is another stimulant that you might not think about. Think about supplements that you might be taking, particularly weight loss supplements or decongestants can contain stimulants without you realizing it. So you may be putting something in your body. But if it really isn't anything that you're ingesting, then there are internal conditions that rev up your metabolism, and your heart responds appropriately to its presence, like your own adrenaline. If you are anxious, or if you have a condition that causes your adrenaline or your stress hormones to be high, your heart will respond appropriately to those hormones, and you'll notice that it's beating faster, and then you have to uncover those hormones. Your thyroid hormone, which regulates your metabolism. If your thyroid's overactive, your heart's going to beat faster. And again, dehydration, keep an eye on that too. So basically, if you've worn a monitor, you have palpitations, and the monitor's saying, well, it's just sinus tachycardia, that suggests that your heart itself, the heart rhythm is not the problem. Your heart is responding to something, and then your doctor's job is to work with you to figure out what it is that's driving the heart to beat fast.
Very good. Thank you very much, Dr. Callback and Dr. Thomas, for participating and taking the time out to educate us tonight. Just so you know, they are both available at the numbers on your screen. And just to let you know also that our next Spirit of Women webinar is on September 16th. It's called Baby Bumps, What to Expect During Your Pregnancies. If you're interested, you can actually register for that right here on the console before you exit, or let people know that it's available. Also, these types of programs have a lot of planning and teamwork that gets done behind the scenes. We have some silent partners that are behind us, giving us moral support, helping us along the way, helping with the slides, and doing all the things that need to be done to put on a program like that. So thank you, Suzanne and Lauren, for all that you do to help us put these programs on for our audiences. So lastly, Dr. Callback or Dr. Thomas, do you have anything that you'd like to say in closing?
Yes, Lori, if you don't mind, I really want to thank you and everyone working behind the scenes. I want to especially thank Dr. Thomas, who I find to be absolutely brilliant, not only in intellect, but in her ability to get the important points across to the viewers during this webinar. And I want to thank everyone involved in the webinar. It's my pleasure to periodically get a chance to share some of what I know about cardiology with all of you who are so engaged for yourselves and for the health of your families. And congratulations to all of you. This was an absolute pleasure.
Great, thank you. Thank you.
Okay.
Okay.
Dr. Callback's, yes, his sentiment. Thank you very much to everyone who organized this behind the scenes. And Dr. Callback, I learned so much just listening to you tonight. So thank you for your contribution and to everybody who participated and who came to listen to us. I get very excited when patients want to take charge of, when you want to take charge of your own health and promote your own health and learn as much as possible. I think that's great because, when it comes to you, you're the boss, and you're the boss of your own health, and you should know everything that we know about your heart. So don't be afraid to ask if you have questions about from your doctor, that you want to ask your doctor about your own health. You should be empowered to do that. And if you want more information, ask for more information, because at the end of the day, it's your body, it's your health, and it's your life.
Very good. Thank you. Thank you. So to our audience, remember to stay home when you can, wash your hands, wear your masks, stay 6 feet apart so you can stay safe. And thank you to everybody for participating with us tonight. And we'll see you soon.